Good morning, very good morning to everyone here. So I'm going to discuss whether incorporating newer diagnostics for IOL selection are an additional need actually required in our day-to-day practice, or they're just a burden and add costs to our working environment. When we travel these days, we attend many forums, we go to many trade fairs, and we see every year after year, newer diagnostics are coming up into the market. They claim to add more data to the knowledge that we already have, but whether it is just an increase in the EMIs for us, or monthly EMIs, a burden to the hospital, is what we need to understand. But before going to advanced diagnostics, I want to bring a point out, is to do a complete comprehensive examination of the eye before planning a cataract surgery. Not only does it mean doing a slit lamp evaluation of the grade of the cataract, but also doing simple tests like doing a Schirmer's to look at the tear film production, and doing a simple test like a tear film breakup time to know about the meibomian gland status of the patient. Also equally important is to look for subtle signs like margins, chronic inflammation at the lid margins, meibomianitis like in this case, or conjunctival scarring and poor fornicis. These conditions will mar an otherwise excellent surgical outcome because patients will blame their surface symptoms, but also more importantly their visual outcome, because dry eye patients will have higher order aberrations because of scatter induced due to an incomplete irregular tear film. So I think if there's one thing that we need to do first is to do a thorough dry eye evaluation of all our IOL patients. A simple technique that also comes into use now is to do a meivography. It can be done by equipments that are available in the market professionally for this purpose, but can also be done like this by using our own autorefractometers or any machines that we have in our clinic which have an infrared camera. By just inverting the lid, all the meibomian glands can be visualized, as can be seen over here. These are meibomian gland tracts and are clearly visible. Any patient with areas of dropout or skip areas is a likely candidate for a potential dry eye at some point in time and needs to be counseled accordingly. A very important tool in our diagnostic environment now is an aberrometer. And there are many aberrometers present in the market. There are some which have pure aberrometry and the others which have combined aberrometer with a topographer, which can give us details like total aberrations of the eye and can help us pinpoint the source of these aberrations, whether they're coming from the cornea or coming from the lens or somewhere else. Not only does it help us assess the complete visual function of the patient, but it is also a very important tool for counseling the patients on what sort of a lens will be preferable for their eye. I'm going to be discussing the iTrace workstation over here. It is a combined platform aberrometer which has a ray tracing aberrometry with a Placido topographer, and this is how the data comes out from the machine. To understand this further, let's see. This yellow box is the total eye aberrations that are achieved by doing a ray tracing of the patient's visual system. There is a Placido topographer which gives us the corneal curvature, and from there we derive the corneal aberrations. By subtracting the corneal aberrations that we pick up from Placido topography to the total eye aberrations that we pick up from ray tracing, what we get is the internal aberrations of the eye. And thereby we can decode the whole eye and find out where these aberrations are turning out of. Since it has a topography attached to it, we also get not only the corneal aberrations, but also basic topography data like the keratometry readings, which can also be helpful in our case because we don't really need a separate topography unit. Also importantly, it gives us the limbus size, but very important, it gives us the patient's pupil size or a mesopic pupil size or a dim light pupil size. And I will get upon this in the later slides to understand why it is important. Extrapolating this data gives us a point spread function of the patient, which means when a light passes through the eye, how a point of light would spread when it reaches the retina. Let's look at a few case scenarios. Here is a patient who walks into a clinic with a good density cataract and a good dilatation, juicy cataract otherwise. But if you look at the endothelium, you can notice this is a patient with classical Fuchs dystrophy. We went ahead and planned a surgery for this patient. It was an uneventful cataract surgery. We took all the care to protect the endothelium. We put an aspheric lens in the bag, and the next day the patient's a quiet eye. But the patient isn't comfortable with his vision and says, "Doctor, I just can't see well at all." This is how a patient looked on the first post-operative day. Not bad for a poor endothelium like that. But what happened? Why is the patient not seeing well? An aberrometry scan shows again, if you look over here, the cornea is clear. The corneal topography tells us that there are no aberrations on the cornea or minimal aberrations. But there is a lot of internal aberrations in the eye that are causing the patient's total aberration profile to go haywire. That is why the patient is not able to see well. Now, why would this happen? It's because the endothelium, the poor endothelium and the guttae are causing us a scatter of light even before the light hits the IOL. And that is the cause of the problem. It is not the IOL and not the surgery, but the patient's poor endothelium which is causing this problem. So in this case, it is very important it helps us to understand that from now onwards, when we are doing a patient with a poor endothelium, we will have to counsel the patients that their vision will not be good no matter what IOL is put in the eye. And maybe in these patients, even though we are confident of a surgery, we could avoid putting multifocal IOLs in certain cases like these. Another case scenario of a relatively young person who walks into a clinic, active person, and keratometries are suggestive of about a diopter of an astigmatism. We go ahead and plan a toric IOL and suggest the same to the patient. But the patient says, "Doctor, I have never worn cylindrical glasses. And why are you advising me a toric IOL?" Well, this is perplexing. Most of the time, all of us face the situation where a patient has a cylindrical correction but never accepts it. And this is because of this. If you notice, the patient's cornea topography tells us in this blue line that they have an astigmatism. But the total aberration profile is very, very minimal astigmatism, because there is an entity called internal astigmatism which is compensating, totally compensating for corneal astigmatism of the patient. Now, if we were to operate the patient and put a monofocal lens in this patient's eye, we will knock off the internal aberrations, and the corneal aberration or the corneal astigmatism will start to manifest in this patient. If you look at the wavefront profile, see the flat wavefront of the cornea is being balanced by the steep wavefront of the lens. And this is an optical phenomenon. And same with the point spread function. Now, if we can now sit down with the patient and make him understand with this machine, with this diagnostic tool, that it is because of this, the internal aberration, that patient is not needing a corneal astigmatic correction. So it is an objective explanation. We went ahead and did a toric IOL for this patient. And this is just a representative image showing how a corneal astigmatism, the blue line, is being balanced completely by the internal astigmatism of the toric IOL, giving rise to an absolutely clear aberration profile of the patient, which is also reflected in the tracy diffraction, which tells about just a 0.25 astigmatism in a patient with a keratometry suggestive of 2 diopters of corneal astigmatism. So it is very important not only for our understanding, but again to re-emphasize as a counseling tool to the patient. Another important point is the angle alpha, and with us in the cataract surgeons, and this has been a little confusing for a while. Now again, going back to the tracy workstation photograph, this is a patient with a multifocal lens in the patient's eye. The blue lines are the anatomical boundary of the limbus, and the blue cross over here suggests the center of the limbus. The green circle is the pupil, and the green square over here is the center of the pupil, which is overlying the center of the limbus. The red square sign over here is the fixation point, or the axis where the patient is seeing from, or the visual axis. The distance between the visual axis and the center of the anatomical limbus, which is the distance of the blue cross from the red cross, is what we call as the angle alpha. Now in this patient, if you notice, all the 3 crosses are almost close to each other. And this is a good candidate for a multifocal, and that is why a multifocal lens was put in the patient's eye, because the center of the multifocality is coinciding with the visual axis. Let's look at a case scenario to understand this further. This is a patient, if you notice, again, the patient's center of the limbus is the blue cross over here. When we do a cataract surgery, we put a lens in the bag, and we understand that the bag is probably going to be aligned with the center of the limbus in an anatomical fashion. But the patient is going to see out of here, which is the red line, which is the red square over here, which is the visual axis. The angle alpha, or the distance between the plus, the blue and the red, is 0.5. It's visible. It's not visible here, so I've put highlight over here. Now, if you go ahead and implant a multifocal lens in this patient's eye, this is how a multifocal lens will sit behind in the patient's capsular bag. Notice it's slightly shifted downwards. Now, if you look at the patient's visual axis, this is where the patient is seeing from. And it is not difficult to understand that the patient will not be seeing from the center of the multifocality, but from the edge of the rings. This is a recipe for disaster. This patient will come to us with all edge glare halos, all dysphotopic issues, and it will compromise. The whole blame will go on the IOL, when actually it was the workup that we should have done, understood the angle alpha, and probably not put an IOL in this patient, a multifocal IOL in this patient. So in our clinic, an angle alpha of more than 0.4 millimeters is a red flag for multifocality. Another important thing that we all do is a good evaluation of the retina using a 90D or a direct ophthalmoscope. Just to re-emphasize, it is extremely important to do peripheral retinal evaluation. Probably you're using by using indirect ophthalmoscopy to look for subtle signs. But as Dr. Viraj had already mentioned, it is extremely important to do a retinal OCT in patients where you do suspect some problems. Now this is a patient here with a good macula, a potential acuity of 6 by 6, but just off the macula, if you notice over here, there is a pigment epithelial detachment which was just picked up on an OCT. Now this pigment epithelial detachment could be, who knows, harboring an SRNVM underneath it and could potentially threaten patient's vision at some point in time. So even before planning a cataract surgery, this patient would definitely need a retinal evaluation to understand what is happening. Another patient, again potential acuity meter suggesting a 6 by 6 vision post-operatively, but it's very easy to visualize. It's a thick retina and there is a dense epiretinal membrane causing the whole macula to come up. This patient again would need either an observation or a retinal treatment at some point in time, and we need to counsel the patient for their visual function because it will not be as good as we would have planned it to be. Again, coming back to what I had discussed before, the pupil size. It is not only important to understand the patient's optics, but to understand how well the pupil dilates in a dim lighted condition or a mesopic environment. Patients who have dilated pupils will, as this experiment will explain you, this is a patient with a pupil size at 2 mm, and this is the patient's aberration profile. As we move down, you notice how the optics of the eye are opening up as the pupil enlarges. And this, as more and more optics will open up, more and more aberrations will start to turn up. In a patient with large pupils at night time or in mesopic conditions, any IOL that you put will cause a problem. So it's good to put an aspheric lens because they will balance out the corneal aberration profile. Also, if patients need to be counseled at dim lighted conditions, certain IOLs like the fully diffractive IOLs might cause more problem in these patients. So it's very important to document the patient's mesopic pupil before planning the surgery and counseling the patient. Just a brief about corneal topography. We have been using corneal topography for a while in understanding patients' astigmatism and the regularity of it. But another diagnostic tool that we have now is the shine fluke imaging, in this case the pentacam. The pentacam takes 25 serial images of the cornea by a rotating shine fluke camera, much like this, and then it gives us an extrapolation of this data. Because it is a slit scan, it is a photograph, we can understand the elevation data of the anterior cornea and the posterior corneal surface. And from this we can derive details like the curvature map, the corneal pachymetry, etc., etc. In a routine practice, it might not be very important. Like, look at this case over here. This is just a representative example. The topography, although suggestive of mild skew in the pupillary axis, is more or less regular and not a very steep cornea. But if you look at the patient's pentacam data, you notice this patient has a very, very highly elevated posterior corneal curvature. It's a plus 31 to a plus 40 here. Now, this probably is a patient with a form-fruste keratoconus, aborted keratoconus. But why it is important for us is because if the patient does not have a good visual acuity post-operatively, it is probably because the posterior corneal curvature is marring the patient's vision and is a source of higher order aberrations in this patient. In such patients, it could be extremely good because we could understand the optics again and explain to the patient that they are probably not suitable candidates for, again, certain IOLs. So just to summarize, these technologies, the modern day investigatives, do add value to our practice, but they are only complementary to our clinical and diagnostic, also and our surgical skills as well. Thank you.